Dear friends, my colleagues, good afternoon, good morning. This is one of the, I think, important lessons in the basic and clinical sciences of the anesthetic course of İSAİK. My name is Mert Şentürk. I'm from Istanbul, Turkey, and I'm going to talk about respiratory anatomy and physiology for the next 1 hour. I don't have any conflict of interest regarding this presentation. This is a huge topic, and therefore I'm going to focus only about some respiratory anatomy and physiologic topics that would be of interest for the daily life of an anesthesiologist, and also I will try to focus on possible questions on respiratory physiology and anatomy in several exams. We'll start with anatomy. We can divide the respiratory anatomy as upper and lower respiratory tract. Upper respiratory tract is important for us, and it is from nose and mouth to the until the end of larynx. Why it is so important for us? Because the upper airway counts for at least or approximately 60% of the whole airway resistance. This is especially important in patients undergoing mechanical ventilation. Therefore, mechanical ventilation instead of mask ventilation is associated with a decreased airway resistance. Moreover, a tracheotomy or tracheostomy is also associated with a less airway resistance compared to endotracheal intubation. Then we will have the lower respiratory tract, and we will have here the classification of the airways. First of all, we all have to know the rules, the classification of the Malampati score, which is very important for us, both for the daily practice and also for the exams. You will have to know also other parameters to predict a difficult airway. Then we have to know about the cartilage and ligaments around the upper airway. Among these cartilage and ligaments, the cricothyroid ligament is especially important because in emergency cases, we perform the cricothyroidectomy through this cricothyroid ligament, which is between the thyroid cartilage and the cricoid cartilage. This can be for a short time, for an acute time, a life-saving airway management maneuver. But as it is very close to the thyroid cartilage, it should be substituted in short time with a regular tracheotomy or tracheostomy. From here, as you can see here, the trachea rings are some 2 cartilages lower than the cricothyroid ligament. Then we have to be familiar with the laryngoscopic view of the upper airway. And here we have the Cormack-Lehane classification, which is also very important for us for the tracheotomy. And we also have to be very familiar with the anatomic structures that we will see with the rhinaglottitis in inspiration and phonation positions under laryngoscopic view. Something about the innervation of the upper and lower airway. For the first part, for the very upper part, for the nose and nasopharynx, the trigeminal nerve, the fifth pair, is responsible. Afterwards, for the mouth, for the 1/3 inferior part of the tongue, oropharynx is the responsible nerve is the glossopharyngeal nerve, which is the 9th pair. The 9th pair glossopharyngeal nerve is also responsible for the gag reflex that we have to know. And below epiglottis, we have the nervus vagus, which is responsible, the 10th nerve. Moreover, we have also the superior laryngeal nerve. The interior branch is the sensorial nerve from epiglottis to vocal cord. And the external branch is responsible for the cricothyroid muscle, both motor and sensorial. We have the recurrent laryngeal nerve. It is the sensorial innervation below the vocal cords. And all the laryngeal muscles except the muscle, cricothyroid muscle, have the motor innervation with the recurrent laryngeal nerve. Let's start with the trachea. The trachea is between the cervical 6 and thoracal 5. We have 16 to 20 hyaline cartilage rings in C form, and here what we have here is the inferior wall. You can also call it D form, but it's a C form. So with this structure, we can easily, we have to differentiate between the anterior and the inferior parts of the trachea, because the bronchoscope can be upside down, the view can be upside down, and this can lead to confusing vision. It's almost 10 to 15 centimeters long in an adult patient. The innervation is with nervus vagus, and the blood circulation is performed by arteria and vena thyroideus inferior. Then we have to be very familiar with the bifurcation. Below bifurcation, as we know, that we have the right and the left main bronchus. Right main bronchus have the first secondary bifurcation at this 2 or 2.5 centimeters below the carina, and this right upper lobe bifurcation is important for us, especially in the thoracic anesthesia for the one lung ventilation. The angulation of both main bronchi is, as you see here, because of the structure of the heart. The left main bronchus has an angle of 45 degrees, and the right main bronchus 25 degrees. That's why if we have a very deep intubation, it goes usually to the right-hand side. This is not the case in pediatric patients. In pediatric cases, we have quite similar angles there, and therefore the possibility of going both sides is almost the same. Then we have on the right-hand side 3 lobes, and in the left-hand side 2 lobes. But in both sides we have 10 segments that we can see here. And we have to be also familiar with the fissura here. That means if we have an anterior-posterior view, what we see in the anterior side is usually the segments of the upper lobe. What we see in the inferior side are the lobes of the lower lobe. That's because of the oblique structurization of the upper and lower lobes. Then we have the classification of the airways. We have until the alveol. So if we consider the trachea as the class 0, then we have to go until the 23rd of class, which are the alveoles. Gas exchange starts in the respiratory bronchioles, which almost 17 or 19. And then no cartilage in the terminal bronchiole. And this will be followed by losing also the smooth muscle support. That means in the distal airways, we have only the gas inside the alveolus and the surfactant, which keeps the airways and the alveolus open. We don't have any cartilage or any support of the smooth muscle. Each sac has approximately 17 alveoli, and this would lead to a total of 300 million alveoli in both lungs. We have to be here familiar with the different types of pneumocysts, and we have to be familiar how and by whom the surfactant is produced. Something about the circulation we have in the lungs, pulmonary and the bronchial circulation. For the bronchial circulation, we have circulation until the terminal bronchi, and almost 4% of the cardiac output is going to the lungs for the oxygen supply. And as you know, we have also the pulmonary circulation, because the resistance, the vascular resistance is lower in the pulmonary circulation. The pressure is also lower. We have here a total of 2 pulmonary veins for 2 lungs and 4 pulmonary veins for each from each lung coming back to the heart. Something about the muscles and innervation of the respiratory muscles and innervation. The most important inspiratory muscle is, of course, the diaphragm. The diaphragm is responsible of the 70 or 75% of the inspiratory tidal volume. It can move in normal resting inspiration. The movement is 1 centimeter, but it can move up to 10 centimeters. Then we have the external intercostals, and here, especially the intercostals between T2 and TH6 play an important role. These are the real intercostal muscles, and therefore the innervation and the ribs play also an important role in the inspiration. Normally, expiration is passive and we don't use any muscles, but for an active expiration, we use the internal intercostal muscles and also the abdominals. Normally, with the movement of the diaphragm, the thorax gauge goes up and the abdomen is going also up. In injuries of the innervation of the respiratory muscles, this can change. Normally, we have here the phrenic nerve, for the diaphragm, which is coming from C3 to C5. Then we have for each intercostal nerve and intercostal muscle and intercostal nerve. And therefore we have to know that the valgus is responsible for the sensory innervation of the trochleobronchial tree. And then we have also the sympathetic innervation from T1 to T4. If we have a cervical spine injury and at the C1, C3, 2 level, a continuation of a spontaneous breathing becomes impossible. If we have an injury at C3 to C5 level, there can be still some inspiratory effort, but probably this would need some support. If it is below C5, then we can use only the intercostal muscles, and therefore we can have, if we have a phrenic nerve injury, similarly, we use only the intercostal muscles. This will lead to a paradoxal respiratory movement in which, yes, the thorax would go coming up, but the abdomen would coming down, and therefore this would mean, as we don't use the diaphragm in these cases, this would mean a paradoxal ventilatory effort. Similarly, if we apply a classical interstitial envelope, it is obvious that we would block also the C3 to C5, and therefore in 100% of the patient, and a unilateral diaphragm paralysis can be expected. In newer approaches with the ultrasound, this ratio of 100% can decrease. Moreover, we have to be also familiar with the bronchoscopic view, and therefore you can find also websites and YouTube videos for videoscopic reviews. One thing which is very important is that the primary bifurcation at carina and the secondary bifurcation at the left main bronchus can be similar, and therefore, especially if you are unexperienced, it can lead to a confusion. Another thing that we all know is the right upper lobe, the vision of right upper lobe. This is the only lobe with 3 further segments, and therefore what we see here is a so-called Mercedes star. This can help us to get oriented during the bronchoscopy. Now, to switch to ventilation, we can start with the central control of ventilation. We had to know the respiratory centers, the 4 respiratory centers in pons and medulla. The dorsal respiratory group here in medulla initiates and coordinates the inspirium. The ventral respiratory group coordinates forced expirium, as it is only the case in forced expirium. And we have to know also the apnostic center, which coordinates the speed of inhalation and exhalation, and the pneumotoxic center, which has similar duties. And how it comes that the ventilation is stimulated in these centers? This is mainly because of the peripheric receptors. In normal, healthy patients, the most important stimulator of the respiration is the change in the CO2 of the blood. This change would lead to a change in pH of the cerebrospinal fluid. And the change in the cerebrospinal fluid, the decrease of the pH in the cerebrospinal fluid, would stimulate the respiratory centers. The PO2, a decrease in the PO2 plays also a role, but this role is less in healthy patients. The role of PO2 is higher than the PCO2 only in patients with a COPD. Why? Because the CO2 in these patients are already high, and therefore the response, the threshold to get stimulated with a change in CO2 in this patient is lower. And therefore, for a stimulation of a spontaneous breathing, the relative lower PO2 is crucial in these patients. That makes, in our daily practice, the weaning of the COPD patients from mechanical ventilation more difficult. This is one of the most important challenges. Similarly, it's not a wise idea, it's not a good idea to increase the arterial oxygen saturation in COPD patients to a very high level, because this will be only the stimulator of the spontaneous breathing. Now we can start with the gas exchange and oxygenation. Considering that we live at the seaside, we have a barometric pressure at the seaside of 760 millimeters of mercury. Then from this inspiratory oxygen would not be equal to the alveolar oxygen pressure. And note that for the alveol, I use an initial A. For the arterial, we use a little a, and this makes the difference. Do not get confused. From inspiratory oxygen pressure to alveolar oxygen pressure, we have to subtract the vapor pressure, the water pressure, and the alveolar CO2. How it comes? Because during the inspiration, in the airways, we saturate the air that we inhale with water. And therefore, we have to first subtract the water pressure here, which is 47. And then we have to multiply it to find the oxygen pressure with the FiO2, which is in the room air, 0.21. And we would have approximately an inspiratory oxygen pressure of 150 millimeters of mercury. Then we have the famous alveolar gas equation. You have to know this alveolar gas equation for each and every possible examination that you will have in your academic life. Alveolar oxygen pressure is the inspiratory oxygen pressure minus the alveolar oxygen pressure. And to calculate the alveolar oxygen pressure, I use the arterial oxygen pressure, you see here, divided to respiratory quotient, which is 0.8 in normal patients. So for a normal, healthy human being breathing spontaneously in room air, this would have 150 of inspiratory oxygen pressure minus 40, which is arterial oxygen pressure, divided to 0.8, which is almost 50. And then we have an alveolar oxygen pressure of 100 millimeters of mercury. Things look like this. If the ventilation is okay, if the perfusion is also okay to bring some CO2 into the alveoli. But this is not always a perfect match, and therefore there is always, or even in the healthy young people, there is always a difference between the alveolar and the arterial oxygen pressures. In some cases, in pathologic cases, this difference may be high, and therefore the PO2, arterial PO2, would be very low, which is a hypoxemia. And there are 5 cases of hypoxemia. This is also another question that you would have very often in every possible examination. I have the hypoventilation, the low FiO2, an increase in right-left shunt, pulmonary shunt, a VQ mismatch, ventilation perfusion mismatch, and a diffusion failure. And you can see here, if we have a pure right-left shunt, this will be the only reason of the 5 causes of hypoxemia that cannot be treated with an increase in FiO2. How can this be possible? We will see in the next slides. To have a good match, what we need a good ventilation of the alveoli, good perfusion of the alveoli, and the ventilation and perfusion should match in an optimal way, which is not always the case. And the diffusion from the alveoli to capillary would be also working very well. Normally, in young patients, there is still a difference between alveolar and arterial, and this is because of the anatomic pulmonary shunt that we all have. With age, this difference would also increase. That would mean I have a higher alveolar arterial oxygen difference compared to you. Therefore, to create to see the pathology, we can use, of course, the alveolar minus arterial oxygen differences. But this is, for clinical purposes, not very useful because of 2 reasons. Because first of all, in every patient, I have to calculate the alveolar gas equation. And moreover, and more important for us, with an increase in FiO2, even in the healthy subject, this difference would increase too. And therefore, we have to know the effect of the FiO2. And therefore, the better way to see the alveolar arterial oxygen difference is this PF ratio or Horowitz ratio, ventilation perfusion ratio that you see here, which is the arterial oxygen pressure divided to FiO2. This is, as you know, also a criteria of ARDS and acute lung injury, and therefore it's very useful in our daily practice. The upper one that you see here is the normal match of the ventilation and perfusion. So this is the ideal case. We have a good ventilation, good perfusion, good diffusion, and all the hemoglobins here are saturated. That's good. Then we have the ventilation perfusion mismatch. Ventilation is good here, but the perfusion is bad, and therefore, all the hemoglobins get saturated, but probably I wouldn't need so much oxygen here. The other way, ventilation is bad, but the perfusion is very well. Perfusion is full well, that only these 4 oxygen molecules would not be sufficient to create perfect saturation of the hemoglobin in the arterial pulmonary circulation. How about the shunt? This one you see here, the anatomic shunt that I have mentioned before. But in pathologic cases, if I have an atelectasis and a collapsed alveoli, this shunt area can increase too. In that case, I would have an hypoxemia. So the difference between the 2 pictures, for the ventilation perfusion mismatch, if I can increase the O2 molecules here, let's say if I increase the FiO2 with, let's say, 8 O2s instead of 4, I can treat here the hypoxemia and the oxygenation would get well. But in a case of shunt, it would not matter unless I cannot open this alveoli. It would not create any change in the oxygenation, how high the FiO2 would be. Therefore, if the cause of the hypoxemia is an increase in shunt, an increase in FiO2 would not help you. This is the famous pulmonary shunt curve, and you can see if I have a shunt of 50%, the PO2 would not change with the increase of FiO2. And this is not the case in lower ratios of pulmonary shunt. And the last case is I have a good perfusion, good ventilation, and also a good match, but the alveolar capillary membrane is so thick that a diffusion from alveolar to capillary is limited. This can lead, of course, to a hypoxemia, in which cases, first of all, if there's a surface tension reduction, if the thickness of the alveolar capillary is increased, which is the case in interstitial lung disease or lung fibrosis, or if I have an interstitial lung disease plus a tachycardia, the time that I would need for the oxygenation here would be too short to have a good oxygenation, and therefore, especially in these patients, tachycardia can be very harmful. We know now, we can explain now these 5 causes of hypoxemia. How about the ventilation perfusion match that we see here in the previous table? You can see here a perfect match of the ventilation perfusion is somewhere around the 3rd rib. Otherwise, both the perfusion and the ventilation would decrease from bottom to top. And the most important reason for this decrease is the gravity, of course. In an erect standing position, both the perfusion and the ventilation decrease. This is a confusion. Many of the people think that the ventilation is higher at the top. This is not true. This is only the case if you compare the perfusion and the ventilation. Both are decreasing. Ventilation is also higher at the bottom part of the lung compared to the top part of the lung. But the ventilation perfusion ratio is different. At the bottom of the lung, we have more perfusion compared to ventilation, vice versa in the top of the lung. That means I have in the bottom of the lung, in the more dependent areas, more perfusion than ventilation. That would lead to the tendency is going to have a pulmonary shunt, and the tendency at the top of the lung is having a dead space because there the ventilation is higher than the perfusion of the lung. The second, first we had the gravity, and the second one, the regulating the perfusion, or is the hypoxic pulmonary vasoconstriction. The name is self-explaining, and it is the alveolar oxygen pressure, which is the most important determinant of the hypoxic pulmonary vasoconstriction. If I have in an alveol a low arterial oxygen pressure, then the perfusion around this alveol would decrease as a result of the vasoconstriction around. This is beneficial if I have a limited area of hypoxic alveoles, which can be the case during one lung ventilation, of course. This would decrease the percentage of the pulmonary shunt. But if the whole lung is hypoxic, if all the alveoles are hypoxic, then I would have an overall increased pulmonary vascular resistance, which would mean a mountain sickness. Think about it. If I would go to the Everest, if I go to a mountain sickness, to a mountain, the barometric pressure would be low, and therefore, as a result, the alveolar oxygen pressure would also be low, and therefore, in that cases, I would have a pulmonary hypertension. So, we see here the two extreme cases. In the middle, we have the normal match. In the left-hand side, we have the right-left shunt, which is the continued perfusion, but no ventilation. And the other way, if I would have a dead space, if the ventilation is going on, but I would have no perfusion at all. How about the PCO2 elimination? For the PCO2, I have a PCO2 equation, and we can see the alveolar carbon dioxide is directly proportional to the production of the CO2. You have to have a dot at the top of the B here. This is the production of the CO2. And it is indirect proportional to alveolar ventilation, because this is the way that we exhaust the CO2 from the body. So the higher the carbon dioxide CO2 production, the higher the PCO2. The higher the alveolar ventilation, the lower the PCO2. And moreover, the alveolar ventilation is the subtraction of the expiratory volume that we see here also on the monitor, minus the dead space. So the higher the dead space, the lower the alveolar ventilation, which is very expected. And therefore, if we have a higher dead space in some cases, especially in COPD cases, the CO2 elimination would decrease. That means an increase in shunt is associated with hypoxemia, and an increase in that space is generally associated with a decrease in PCO2 elimination. What we see here is the capnography. You have to know, of course, the entitled CO2 and the capnography. I will not go into further details of this monitoring, but capnography is the most important and objective monitoring device of a tracheal intubation. Moreover, it would give us some hints about, first of all, about the degree of your ventilation, whether you're hypo or hyperventilate. And moreover, it would give also some idea about dead space too. The higher the dead space, the higher the difference between the arterial CO2 and the entitled CO2. Normally, you would calculate the dead space with the ratio of the dead space to whole tidal volume with a subtraction of alveolar CO2 minus mixed expiratory CO2 divided to alveolar CO2. This would give the ratio of the dead space. But as it is too difficult to calculate, we can surrogate the alveolar CO2 with arterial CO2 minus mixed expiratory CO2 divided to arterial CO2. This is the Bohr equation. How do we breathe? Normally, there is the most important difference between the spontaneous breathing and the mechanical ventilation is that at the end of the expiration, in any case, it is the balanced situation. So there is no pressure gradient between your alveoli and the outside. To create an inhalation, what we create a negative pressure within the thorax. So the gradient, the pressure gradient during spontaneous breathing is from zero outside to negative inside the thorax. How can I create the negative pressure at the alveoli? Normally, the pulmonary, the pleural pressure, intrapleural pressure is always negative compared to alveolar pressure. And therefore, I have here always a transpulmonary pressure. If I increase with the contraction of the diaphragm and expiratory muscles, the pressure in the intrapleural space is getting more negative. As it is getting more negative, it creates also a negative pressure within the alveoli. And that's the reason why, how can I create a different pressure gradient and the air flows into the alveoli? How do I do it during mechanical ventilation? With the exceptions of this historical ventilator, all mechanical ventilation today is almost all are done with a positive pressure ventilation. That means there's no change in the pressure within the alveol, but I create a positive pressure, so the outside. So the gradient during mechanical ventilation is from positive to 0. What is the important gradients here? I have here a transpulmonary pressure, which would create here the inspiration. It's not easy to measure the pleural pressure, but if I have an esophageal balloon, this is a good surrogate, a reasonable surrogate for the intrapleural pressure, and therefore I can measure here also the intrapleural pressure as a surrogate, and so that's also the transpulmonary pressure. Otherwise, there's the transpulmonary pressure is the gradient between alveolar and intrapleural pressure, and normally you will read the trumpet. For the trumpet player, they create a huge pressure in the pressure gradient in the alveol, and that should lead also a pneumothorax. Why we don't have any pneumothorax in the trumpet players? Because the transpulmonary pressure, which is a subtraction of alveolar and the intrapleural pressure, is the same. So the decrease in both pressures are the same, and therefore we don't have any trauma for the hard and deep inspiration. Also, even if you play a trumpet. Something about the respiratory mechanics now. We have to deal with two types of pressure during the gas flow from outside to the alveol. First we have to cross the airways. And for the airways, we have to deal with resistive pressure, first of all, in the airway. This is the same, actually, equation that you can remember from the high school in the electricity, the Ohm rule, in which the resistance is equal to pressure gradient divided to flow. Okay? And here we have the flow of gas flow, and the pressure gradient is between that we create within the airway. So the resistive pressure, therefore, if you turn the equation, is the flow times the resistance in the airway. That means if you have an increase in the resistance airway, which is the case in the COPD patients, the obstructive lung diseases, the transfer airway pressure will be higher than expected. The second one is the elastic pressure. Here we have the balloon. Now we don't have any flow anymore. We have here the volume, and the more quality the balloon has. Think about the toy as the balloon as a toy that you give to your children or nephews or something like this. If it is a good balloon, you would require less pressure to create a balloon, okay, to inflate the balloon. And that means the quality means here is the compliance of the balloon, which is the compliance of the alveoles. And therefore we have here the volume instead of the flow. And this makes the compliance. And the compliance is the volume, the pressure that we would need to create a volume within the alveol. And therefore, the higher the compliance, the lower the pressure that we need. You can see here volume, the pressure is equal to volume divided to compliance. This is the case if we have a restrictive lung disease. Remember, for the resistance, we were talking about obstructive lung disease. In the restrictive lung diseases, the compliance is lower, and therefore here we have to deal in these cases more with the transthoracic pressure instead of the transairway pressure. And we will see here also in the daily practice. So considering that we don't apply any PEEP or the patient has no auto PEEP, the whole airway pressure that we have to deal is the addition of the resistive pressure, which is flow times resistance, plus the volume divided to compliance, which is the elastic pressure. If you have a patient undergoing mechanical ventilation with, let's say, volume controlled ventilation, and if this is a patient with an obstructive lung disease, then you would need a higher trans-airway pressure. This would show itself in an increase in the peak airway pressure. On contrary, if you have a restrictive lung disease, if you have an ARDS patient, or let's say a pneumonia or similar, then you would have some problem in the compliance, and this could show itself in an increase in plateau airway pressure. And so you can make a difference about the location and the pathophysiology of the disease. Let's talk about some terms in respiratory mechanics. What is compliance and resistance? First, about the compliance. In the previous slide, I have said something about the analogy of the balloon as a toy and the alveoli. As a matter of fact, think about it. If you want to inflate a balloon, which is a total empty, a collapsed balloon, you will require a very high pressure. This is a physical rule, that is a physical sense. Look at here. For the zero volume, to create a volume within the balloon, you would need a very high pressure because the compliance here is very low. Afterwards, if you have some volume within the balloon, you would recognize that you would need lower pressures to create a high, same volume within the balloon. That means the compliance of the balloon is in that area, in that green zone, let's say, higher, better. And finally, if there's too much air within the balloon, you would recognize, you would think that, oh yes, maybe this is a little too much and there's no more space in the balloon, and therefore the compliance is getting again lower. What is the functional residual capacity good for? Because of the functional residual capacity, even at the beginning of the inhalation, at the inspirium, I have some air in my balloons, in my alveoli. And therefore, in normal healthy patient in an erected position, I start the spontaneous breathing with some volume within the balloon, and therefore I need lower pressures to create the tidal volume. That means I already start my inhalation somewhere around the lower inflection point of that sigmoid curve of my compliance curve. Okay? That means the respiratory system compliance is the ratio of tidal volume divided to alveolar pressure. What does it mean to me? To create the volume, I need the change in how much change do I need in the pressure to create the same tidal volume. The higher the pressure that I require, the worse the compliance. The lower the pressure that I require, the higher compliance. In the spontaneous breathing patient, I have the alveolar compliance and the chest wall compliance. And the total compliance is the sum of the reciprocals, not the direct the addition. The addition of the reciprocals of the alveolar and the chest wall compliance. And this would give me the total compliance in a spontaneous breathing patient. For the compliance during the mechanical ventilation, I had to differentiate between the static and the dynamic compliance, but this is something else that we are going to talk about maybe in next lecture. How about the resistance? So, if I have, first of all, stay in the compliance, if I have a patient with a restrictive lung disease, the whole compliance curve getting lower because I would need a very higher pressure to create the volume in the sick alveoli. For the obstructive patient, the compliance curve would look like this because compliance in the obstructive patients is even better, even higher than the healthy patient. the problem in the obstructive patients is not the compliance, it is the resistance. In these patients, I would have to deal with a very high resistive pressure in the airways and not in the alveoli. And therefore, the resistance is, as I have mentioned, something like the Ohm rule, is the ratio of the delta pressure divided to flow here, okay? So, how can I see this in the volume controlled ventilation? For the flow, the peak airway pressure is responsible. Therefore, if I see here a very high peak pressure and the plateau pressure where there is no more flow, there's a pause section of the inspirium. If the plateau pressure is normal and I have a very high peak pressure, I have to think about an obstruction in the airway, either an obstructive lung disease or an obstruction totally in the airway. If the peak airway pressure is okay, or if the difference between the peak airway pressure and the plateau airway pressure is higher, so that means I have a peak airway pressure, but a normal plateau airway pressure. These would speak for a obstructive lung disease. But if the peak pressure is also high, if the plateau pressure is also high, the plateau pressure is the pressure that we see without any flow. This is the show of the pressure of within the alveoli. That means I have some problems within the alveoli. I have some problems with the compliance, and therefore this would speak for a restrictive pulmonary disease, an increase in the plateau airway pressure. Okay? Something similar like it is the case in the spirometry. For the spirometric measurements, normally during the expiratory phase, the forced expiratory volume in the very first second is 25% of the whole vital capacity, forced vital capacity. If there is an increase, if there is a decrease in this ratio, this would talk for obstructivities, because consider I have some problem in the airway and therefore the flow is lower, the resistance is higher, and therefore I need some more time for the whole expiration. In the other case, if the ratio is higher, but the total vital capacity is lower, that would mean that the balloon was not filled, or it was filled with the filling of the balloon was problematic, and therefore the decrease in the FVC would speak for a restrictive lung disease. And a problem within the alveoli, within the parenchyma of the lung. A decrease in this ratio would speak for a problem in the airway and for an increase in the resistance in the airways. So the combination of the resistance and the compliance would give me the term of work of breathing. Again, something physical. The multiplication of the compliance and the resistance is the work of breathing. The energy that I would require to create a spontaneous breathing, to create some air in my alveoles. And this would again be the addition of the elastic work, which is here for the to create a volume within the alveole. And plus the resistive inspiratory work, which is the work that I have to apply, the energy that I have to apply to deal with the resistance in the airway. If I have some lung diseases, the area that I have to calculate would be bigger, greater, and therefore I would need a higher, an increased work of breathing. The higher the work of breathing, the higher the requirement for a mechanical ventilation, or let's say the higher the requirement for a support for the ventilation. Okay? And I think that was it. And thank you very much for your attention. Changes in the physiology of the respiration during mechanical ventilation would be also some topic of the next lecture, the lecture about this mechanical support in lung injury. Thank you very much for your attention.